So it's a pleasure to introduce our third speaker for the session, Michael Sullivan. So Michael is from the University of Auckland, and looking at Michael's research publications, there's a breadth of applications from healthcare to scheduling to supply chains and many others. And looking forward to hear about your talk now with modeling AI in healthcare. Thank you.
Cool. Thanks, Yoni. Appreciate it. And thanks very much for the opportunity to talk today. There is a breadth to my research, which is one of the nice things about doing operations research and modeling is you get to use it all kinds of places. And today I'm going to concentrate on where I've used it in helping in the management of healthcare systems. So first I'll do a quick intro to myself, and then we'll get into it. Cool. No airani me haina o ko tupuna, ko Sullivan toko whanau, ko te arasu toko hapori, e noho ana o ki ngā whenua me ngā wai tapu o te kawarau amaki. Tēnā kamihi, tēnā koutou. So the translation for that's just underneath. It's a little bit about myself. I come from Ireland and China, although I have to say I did Ancestry.com recently. And it turns out most of my Irish ancestors must have come from Scotland because apparently I'm 37% Scottish. I work here at the University of Auckland, where I run a research group, Aurora, which looks to combine operations research and analytics. I did my bachelor's and master's here before heading to Stanford for my PhD. I wear lots of different hats, which kind of goes with lots of my different publications across operations research, but also complex systems. And Te Punaha Matatini is a centre of research excellence in New Zealand on complex systems, and some of that work has come through here. I've also recently been really lucky to be involved in the Global Partnership of AI, which has been really interesting in some of the work on public policy modelling is sort of going to be continue on in that. With that hat on. So today I'm just going to talk about a few definitions of defining some of the terms I'm going to talk about. Hopefully you've seen some of them. Some of them you may not have. For instance, Healthcare 4.0, and probably the definitions is more about making sure that we're all talking the same language, because often different words mean different things to different people from different disciplines. Then I'll talk a little bit about why you should care about my talk. And then I'll just get into a whole bunch of case studies of us using modelling and AI to help the management of healthcare systems. And then I'll wrap up with sort of final thoughts about what I hope you've taken away from my talk. So modelling and artificial intelligence as tools for healthcare management have been around for a long time. So the first model we did, which was a simulation of the Student Health Centre, happened in 2009. That happened because my colleague Cameron Walker and I both had young kids and got sick of waiting in EDs or ERs, they are other places. And then I started talking to a nurse who was bandaging up my arm because I'd fallen over playing football at the health centre, and started talking to her about how things ran. She talked about some various bottlenecks, and so we did a simulation to try and help, see if we could help alleviate those bottlenecks, or at least understand how they're caused. There's a poster from the project that followed down below. And then over the last couple of years, a little bit, we got sidetracked by the pandemic. I did, myself and some students did some simulation of another medical centre up in Dargaville, which is in the far north of New Zealand. And we had a discrete event simulation for them to understand the effect of their rosters on patients coming through, and if they could put a phone triage facility in place and if that would help. And so the two screenshots on the right, the top one is a simulation inside a open source simulation package called JAMSIM, and down the bottom is what we call we're calling it a few things now. Now we call it a behavioural path of a patient moving through, so sort of arriving, going to reception, triaging, et cetera. And I'll talk a little bit more about some of the discrete event simulations later in the talk, but just to show, those are 10 years apart. And I still think there's more work to do in terms of helping the health system, particularly recovering from COVID, Also some change management to get some of the clinicians to maybe use some of the tools and the methods that we all know work. But there seems to be a little bit of resistance from the health sector, and I can briefly touch on that as we go through. So the other thing I think is really important, and what gives me a little bit of hope for what we do in practice, is the idea of digital transformation. And for me, digital transformation is just putting lots of digital things in place. But I thought for this talk, I'd go and have a bit of a look on definitions. And I really like this one I found. You can see the references down the bottom. But I think it's more than just making things digital. It's also looking at how can we improve things, what new services can be built, what services can be made more efficient by the use of digital tools. And so a lot of what I'm talking today, I think, is based around the assumption that this digital transformation is coming and not only allows us to do what is currently done better, but also to do stuff that maybe doesn't even exist at the moment. And I'll talk a little about some of those possibilities as I go through. So when I talk about digital transformation, I'm not talking about just moving from paper to electronic form. It's also about thinking about all the possibilities of what digital technology may be able to provide in terms of healthcare, but also linking into AI and data science and machine learning, et cetera, et cetera. And that brings me to the idea of Industry 4.0, which you may or may not have heard of. It's quite a buzzword that's been going around for a little while now. And this is an example from some other work I do in construction of looking what Industry 4.0 is like across different sectors. So you can see their manufacturing, it goes from mechanisation to then using electrical energy to then digitalisation, and now getting into 4.0, which is really this idea of cyber physical systems, so digital and physical systems working together, lots of data, lots of sensors, integrating things together, and what can that mean? And you can see there on the right that a lot of the stuff is sort of partly around or not yet there. And I would say that health is probably more in the 3.0 than the 4.0 state, but that's certainly a discussion I'd be interested to have if we have time with questions. And so for me, Healthcare 4.0 kind of has two situations. One is a clinic or a GP practice, so really primary or probably secondary care. The other one is when we get into tertiary care or even quaternary care in hospital. Here's in terms of those different components of what Industry 4.0 looks like: Internet of Things, artificial intelligence, big data, and sensor-based technologies. So those are just some ideas of things that I think could happen within health that would be enabled if we move to enabled by digital transformation. As we move to Healthcare 4.0, the ones in green, ones that I've sort of had some involvement with already. So I've worked in some of those areas like clinician rostering, for example, and the ones that are underlined are some of the ones I'm going to talk about later on today. So I think we are moving towards a Healthcare 4.0. The digital transformation of society, I think, is really helping, but I think there's a massive opportunity for tools around automated management using AI models, machine learning, etc. And I feel like the audience here is probably the people who should make that happen. We just got to get clinicians to listen to us a little bit. And again, I'm biased because that's my experience. So if there are any clinicians in the room, I hope you are listening to us, or the modelling people in your area. One of the key components I think that is going to be very useful and that I've seen be useful in construction, for instance, is the idea of digital twins that I'm going to talk about next. So the idea of a digital twin is you have a digital copy of something from the physical world. And so you can see here, this is more at a city level, where we have the physical system over here on the right. We integrate information from that through sensors and Internet of Things. We then, in this case, go into a model, which is a building information management, and that then enables us to look at a digital twin of things. We can then interact with that digital twin in all kinds of ways. So particularly in construction, augmented reality is really interesting, where you go to a building site and then you put on an augmented reality visor, you look through your phone, and it will then can put the image of what's going to happen next on top of that site. So you can go and explore a site and what it's going to look like using augmented reality. You can also, that can help you engage the digital twin as it moves through time. So as the data updates, you can then see things that are happening that may help you understand if something's running behind time or there's a bottleneck somewhere. But also you can use the digital twin as a model to sort of predict forward what's going to happen, and that enables you to do a lot better planning and control. And I guess where this workshop sort of aimed is this idea of this management here. But I think the digital twin is a key part of how can you manage things well using all the information available to you in a way that's not overwhelming. So this is a little bit what it looks like for healthcare. So this is a simulation of a hospital in Thailand. And so they have what they call like a patient fitness. It's not quite fitness, but essentially it's sort of a one-stop shop. You go in, you select a plan, and you get lots of different tests and see doctors and nurses and all sorts of things. So you sort of get a checkup. And so you can see here there's some scanning machines, there's waiting rooms, there's consulting rooms, and while this was not done with real-time data, so this was more looking at different ways of moving patients through the system to try and make sure that resources weren't waiting. It is the sort of thing that I could see happening in the health system, of having real-world data move into this, and it might be, hey, we've got a bottleneck over here, we need to bring another nurse over here to help move people along. And some other work, which I'll touch on later, is looking at, we're looking at moving nurses dynamically between, for example, triaging and consulting with patients to try and make sure you can alleviate the bottlenecks in real time. And I think digital twins would be a good way for people to make those decisions, but also see what's happening and mitigate issues as they're arising. Also fast forward to see if there's issues coming up. So, and a lot of us do that with our simulations. You run your simulation, you see what's going to happen next. But also one of the things I think which is really important is the idea of replaying, which is where the problem happened, you get your digital twin, you go back in the data to see how did that problem happen, and are there ways we can mitigate against it going forward. So I think the idea of embedding simulation with real time or near real time has a lot of potential benefits for helping manage healthcare systems in a much more dynamic way and having good visibility of what might be coming next using historical data of what happened or nice models of what could happen. So you don't feel free not to read this whole slide because I'm not going to, but this is an example of what I think healthcare 4.0 could be. In green, sorry, it's a little bit hard to see. In green is stuff that we've done already. In orange is stuff that I think is up and coming, and the other stuff is kind of what I'm dreaming about. And so essentially the idea is, as soon as a patient arrives, they scan a QR code. The QR code then tells them on their phone exactly where to go. So it's kind of like a Google map through the hospital. You get to walk to your appointment, wherever the clinic may be or wherever you need to check in. In the meantime, all your data is being uploaded to that clinic, so they have it on hand as you arrive. And also it's maybe sending a message to a family saying, hey, they've arrived at the check-in station. Then as the patient's reviewed, you'll have different views of the data that will be surfaced in the right way. So for an instance, an anaesthetist might need to know about any cross-contamination, that's the right word, any conflicts of medication, and surgeons might need to know about complicating conditions and so on. And so the idea is your data then gets surfaced in the right way to the right person. The scheduling is all done automatically, and I'll show you some surgical scheduling in a moment. So we know that we're using our operating rooms as effectively as possible without overloading our surgeons or causing lots of overtime. Patients get picked up and dropped off at the right time. So orderlies are moving around the hospital. You've got the right number of orderlies. You're not sending them on you're not sending them from one side of the hospital to another, so they can each work in their zones, or where they drop someone off, they maybe wait and pick someone up nearby, and so on. Same to do with the equipment and supplies, all comes together. Administrators can see what's going on, and I talked about that a little bit, the digital twins and so on. And one of the things I think is really important, I touched on it before, the fast forward and the replay, is the idea of continuous improvement. So using a digital twin, you can always look to see where are the bottlenecks, what's happening, are there ways we can improve, rather than doing big improvement projects very periodically. So you're using your data in a very dynamic way to try and make your health system work as well as possible. Okay. So that's kind of the definitions of what I think healthcare 4.0 looks like. The reason for it is this. Waste in the health system is very high. And I don't think, well, from my perspective, working with the health system, that's not because of a lack of intention or a lack of effort from the people in the health system. It's just complicated. And so, as you can see from the slide here, the value or the amount of waste because of administrative complexity or failure of coordination or failure of delivery is very high, and actually the potential savings from mitigating against those is also very high. And so I think it's not due to lack of effort, it's just hard and it's complex. And luckily, most of the people who are on this call, I'm sure, like dealing with complex things and want to solve complex problems, and would like to be able to help. And so I think the point of why should we use modelling and AI for healthcare is we can save them a lot of money, which I think is good, and we can help. And also we're targeted at the right place, which is it's complex. Things need to be coordinated. Things need to happen together. It's a complex system, and that's where I think modelling and AI actually has a lot of advantages over humans. I think we're very good at doing complex problem solving, but doing it continually all the time is very difficult. And what we want to avoid is things like this. So that you'll notice all of these, all of the dates of these are 2021 or 2022. So New Zealand, the health system is creaking and straining, and we're not the only place. Also, you can see there's one for the UK. I think we need to help. Not only do I think we can help, but I think we need to help. And if you're in a place where healthcare system is working perfectly fine, that's great. I'm not, so I want to be able to help. And I think we can, with digital twins, with technology, with going to healthcare 4.0, a lot of the stuff we can do can help. Okay. So I hope you all now understand what I'm talking about and realize that what I'm talking about is important, because now we're just going to get into it. And so I've got a bunch of different case studies here, and I'll go through and talk a little bit about them, and then be done within half an hour. So in terms of healthcare 4.0, I've done quite a lot of work in simulation and a little bit of optimization. And so I'm just going to quickly go through some examples, then we'll get into some of them more depth. These little crosses here are the different hospitals or different areas we work with. So different colors are different ones. So you can kind of get an idea of it's not just all one off with one hospital. We're working with lots of different places throughout New Zealand. And we've tried to do a little bit of work with Australia and China too, but they're not on these slides. So we've done modelling of emergency departments, and that is really about have they got the right mix of people available. Most emergency departments or emergency rooms have a target of trying to get people out in New Zealand. I think it's you want to get 95% out within 6 hours. I heard a story of someone who went there and said, look, the expected time for them to get seen was 10 hours. And he went and asked someone, is that accurate? And they said, no, it's probably more like 12 or 14. So understanding what staffing levels they need to meet those targets, maybe how they prioritise patients to meet those targets have been sort of the focus of some of those simulations. Similarly, with a cytology lab, that was about a lot of switching around to do diagnostic tests. Do they have the right number of FTE? And also the effect of uncertainty on the productivity of those FTE. So a lot of when we worked on that, the staffing model was based on averages, which means you expect them to get the same workload every day. We all know that doesn't happen. And so actually the variability in workload meant that they needed a slightly higher FTE than they'd allowed for. and change the FTE just a little bit. I think it was like 0.3 of a FTE. Sorry, FTE is full-time equivalent. 0.3 of a full-time equivalent changed the workload of the clinician significantly.
Right.
We've looked at cardiovascular ICUs. That's the main impediment there is the number of nurses you need to look after patients and how many patients you're looking after. Orderly transits, moving people around, I'm going to talk about later. Radiology booking, I'm also going to talk about later. And that's that picture there is showing patients with different conditions, but also different priorities. So the label is their kind of condition or what they need, and then the color is their priority, and it's moving through some CT scanners. I'll talk about that a little bit more later. We've also done, as well as discrete event simulation, done some bootstrap simulations. And what I mean by bootstrap simulations is essentially just running historical data through our simulations, and then also doing sampling of similar patients to try and add some variability in there. We looked at that for cancer pathways, but also ward occupancies in one of the biggest hospitals in New Zealand. And so the graphic on the right is the ward occupancy. The colours is blue as a man and pink as a woman, and that's to look at, they tend to try and have people in rooms segregated by genders. In some cases, the red ones are people who are actually being brought in from another ward because that ward's overflowed. So there's sort of the idea of how much overflow do you have from one ward to another. And the key reason for that is mostly the ward will be equipped to handle someone from the overflow ward for a location will be equipped to handle that, but the doctor may not be able to find their patient very easily because they don't know they're there, which gets back to the idea of coordination, but also when wards overflow, things get a bit more difficult, and that's that idea of it being a complex system. We've done some general medicine registrar rostering and some surgical scheduling I'll talk about later. The general medicine registrar rostering, I'm not going to talk about, but one of the interesting comments we had from someone who was an operations manager and been doing it for over 10 years was that she said that this roster doesn't look like anything I ever would have, but it's really good. And actually the implementation of the roster, one of the rosters we came up with at Waitakere Hospital, which is the little black cross, they said it was one of the easiest roster implementations they'd ever done. So I was really happy. It shows that, AI and modeling can actually be used in practice successfully. So that was pretty cool. In terms of healthcare simulation, the one I'm going to mostly look at is improving patient transits. When we got involved at a particular hospital, only 50% of them arrived in an acceptable time window, which is sort of no more than 15 minutes late. They did some lean process improvement, and they managed to get it to 75% in the acceptable time window. And then they wanted to get it up to 90%, and they wanted to know how many orderlies would they need and transit nurses would they need in order to make that happen. The transit process itself is pretty similar, and so it's done at Auckland City Hospital, which is Blue Cross, North Shore Hospital, which is the Red Cross. A transit gets requested, the orderly and transit nurse go get the patient, they pick up the patient, they travel with the patient, they drop them off, and then it's done. So the actual for a single patient is quite simple, but when you're doing it lots of different locations throughout the hospital, becomes a bit more complex. And so this is a simulation of North Shore Hospital. We'll see how the video goes over Zoom. Here's the orderly base with the orderlies, and then patients will appear. They need to get picked up. The orderlies will go, pick up the patients, travel with them and take them to where they need to be for treatment, or pick them up from a treatment room and bring them back to the wards. So using this simulation, we helped them figure out what roster of orderlies that they needed, and we adjusted that by hand, but we would simulate a bunch of different rosters to make sure that they would pick up the patients within, or 90% of the patients within their what they consider the on-time window. And where this works means that you then have transit requests in a roster. You can run through, simulate them, use a simulation I just showed you. Then you get this distribution of how many get in the on-time window, how many end up showing up early. And actually showing up early is, while it's not quite as bad as showing up late, it's also not that great because they may not have the nurses or the clinicians to look after a person who's there early and waiting. But then you can then start looking at, as we change our rosters and run through the simulation, can we get more and more people in that on-time window? And so some of the suggestions you made around the rostering were also implemented at North Shore Hospital. On top of that, a colleague of ours, Nick Furian from TU Graz, also looked at, well, could you optimize that dispatch? The tough part with optimizing the dispatch is that if you need a transit nurse, and the transit nurse is often needed for people with serious conditions. So I had some heart issues in 2017, and every time I traveled, I needed not only an orderly, but a transit nurse along with me, monitoring me. And so then you have this added complexity of the nurse having to go to the transit 2 from orderly 1 and transit 7 from orderly 2. So if orderly 1 is running late, then that might make orderly 2 run late, even though they could be there on time. And so Nick did this as kind of a vehicle routing model with tricks, and he ended up getting some nice results. We then talked to the hospital about if they were interested in implementing it, and notionally they were, but actually at the time, this was a few years ago now, they weren't getting their data in a form that would be easy to implement this. There's also a certain amount of change management and dealing with IT people at hospital in the end. I think what they said is, we'll just put that in our procurement document for our next information system. So they decided that anyone who could do an information system could also optimize dispatch. So that's sort of an example of busting into some change management, which has unfortunately been relatively common in some of this work. So that's patient transits. A few other ones. We did patient transit, so that was the simulation. Some of that was also, we also looked at other work that patients do, which is rubbish and linen collection. And as part of that work, they were putting a business case together for adding extra wards to the hospital, and they were wondering about using automatic guided vehicles or robots. So you can hear some AGVs down the bottom, which bring supplies to various places. And so we said, okay, well, let's do a simulation. And they wanted to look at, well, what happens if we have one elevator shaft for clean and one elevator shaft for dirty, or can we have one which does both clean and dirty? And so, again, we ran some simulations, and you'll be able to see in a minute a robot's going to come over. It's got some clean linen there. It'll bring it up in the elevator shaft and drop it off to the right location, and then come back. There's another one going. So, just in the interest of time, I'm going to flick on from this one. I'm going to pause this one. So again, this was just a chance to use simulation to look at how many AGVs would they need, how many elevator shafts would they need, and give them a really good idea of the cost of this sort of innovation before they went ahead and built it. So this is sort of more traditional simulations. You're not talking real-time digital twins. It's more about using the modeling to help the big CapEx investment. And this is a similar one. This is looking at the radiology pathway. So again, you can see the different patients coming in, different classes of patients coming in here, and they move through, and then they get prioritized, and they go to the various CTs. One of the issues they had here was equity, and anyone who's done any ED modeling knows that ambulatory patients often end up being left for a long time because they have a lower priority. I don't remember, Peter, if you're involved with work with Ilse Zedens on accumulating priority. I think so. Yeah. So there's ideas of accumulating priority. So if you have a low initial priority, but you wait a long time, then you should be seen. And so using this idea of pathway modeling for radiology, we could also look at equity of the different types of patients, but mostly it was around determining how many CTs they need to invest in over the next, I think this was looking at out 10 years to make sure that they could see the patients within the timeframes they wanted as their catchment grew, as the population of catchment grew. So again, this is an example of using simulation more for long-term planning as opposed to in real time. This is the general practice clinic I talked about, so I won't get into it too much more. It's quite a large practice, so it's about 15,000 patients, 12 doctors. It's over quite a large area, so sometimes patients have to travel pretty far, and so they wanted to look at if they could convince more patients to do phone triage first. That might save some people driving in. How much did they need to staff it? What kind of conversion rate of patients walking into patients calling in did they need to get good savings in terms of doctors being able to see more of their appointment patients and so on. So again, this is more looking at if they change things to the system, kind of scenario analysis. If they change things in their system, what would the effect be? And I guess that gets back to the idea of administrative complexity. So it's really helping people deal with that administrative complexity and explore ways to change their system without necessarily having to try it in the real world and not knowing what's going to happen. This one I'm not going to talk to too much, except to say that this was an example that Nick Furin also used, where he combined simulation optimization and machine learning to essentially learn what the optimal prioritization of patients in an ED would be, and then use that machine learning in practice. And he found that by analyzing the various different queues, and so depending on what your queue links were, you would see different patients at different times. And so this for me was really right at the cutting edge of what might be possible in Healthcare 4.0, and that we can really use our tools to do a customized what's happening in our system. Okay, we need to do this in order to get our system working as well as possible. So rather than just having one rule that you follow without seeing what's going on, you actually observe all the different queue links and then decide, okay, that patient needs to be the next one that we see. Okay, so that's simulation. I'm just over a bit over halfway. So time-wise, I'm going to go through the other one. I might skip one of the modeling for policy ones, but we'll see how we go. I don't think there's too many more slides, actually. So in terms of surgical scheduling, there's sort of two ways, or two things people are concerned with. One is, what are they going to do in the next couple of weeks? And that's usually because you're fixing your schedule to let patients and surgical teams know. There's also the long-term one. I'm not sure how it goes with all of you are, but I know the waiting lists for elective surgery in New Zealand are really long due to COVID, and they're not getting any shorter. And so you also want to see, well, how long is it going to take us to get through our current waiting list? Do we need to add more resources to try and get that time down? And so in these pictures, I'll show you each one of these rows is going to be a session in the theatre. So that's on it's in theatre 28 and it's AED, so it's all-day session. That's in theatre 22 and it's AM. So it's a morning session. It's on Thursday, the 21st of some month. So I'm just going to show you a few of these pictures and our automatic scheduling algorithm. There's a few things that our algorithm balances, the idea of overtime. So as you put more operations in, and this is actually really the mean operation, then the probability of overtime goes up, depending on your variability. So the two things we're using here is we use the mean of the surgical durations and the variance of the surgical durations, and then we do predictions on, if we combine all those surgeries together, what's the likelihood of going past the time that we're trying to slot them into. And I'll skip over this. This basically just shows we're using a few different methods to predict that overtime, and actually it's sort of hardest to predict around the 20%, 40%, which is possibly where you're aiming. There's certain combinations are going to go over time, and they're easy to tell, but it's really this sort of sweet spot also where some of the prediction is difficult. And one of the things we're trying to do is we're trying to get lots of patients through. So there's the throughput here on the y-axis, but we don't want them to wait too long. So you can see there's quite a curve here in terms of we can probably get, a good number of patients through without making them wait too long. But if we try and get much more through, then the patient's just going to get waiting longer and longer. And so we've got various different exponents on that waiting time that allows you to then explore that trade-off in quite a dynamic way between getting patients through but not making people wait too long. And so we have an optimization algorithm. It's a relatively standard MIP in terms of, if this surgery is placed in this session, then it's a 1, otherwise it's a 0. And we've got it running on some real-world hospital examples. Here's an example of what was actually scheduled, which is in red, versus what the optimized did. And this is how late. So you can see there's an interesting there's a bunch of people who are early, but there's quite a bunch of people who are late in the scheduled one, whereas in what we do, there's a reasonable number early and most people show up sort of on time. And in terms of, so that's making sure people don't wait too long. And in terms of overtime, you can also see there that optimized overtime is bounced around 0. There's a bit of a tail there, which we've been exploring, whereas for the scheduling, they are mostly going overtime, although not by too much. So it might be that a certain level of overtime was acceptable to the hospital. And we're working with the hospital now to try and put this in place in a side-by-side test to see how it might work in practice. Although I should say all of these based on historical data from a real surgical unit. What this plot's showing is for the optimization, we get through more people on most days, that's the green, and actually we ran our surgeries more quickly. So we also get through the entire waiting list more quickly and actually with less overtime than what they'd scheduled in practice. We have had it pointed out to us that there may be some other considerations they take into account when they're scheduling the surgeries, and I think that's probably fair enough, but that's why we're working with them to understand that. The plot in the middle and the plot on the right is the actual versus optimized in terms of what surgeries are scheduled at the start. You can see a mix of blue and red, which means some of those surgeries are running late, which are the red ones, and some of those are early, which is the blue ones, whereas the optimized one is mostly doing the late ones. But then in the next plot, this is a few weeks on, and you can see here the actual one is still doing some that are late and some that are early, but the optimized one is now caught up. So most of the surgeries planning are now pretty much on time, maybe a little bit late at those pink ones. So the optimization has prioritized in terms of lateness in the right way, because it's now managed to go to everyone's pretty much getting in either earlier on time, whereas the actual one, they're still struggling with some people being quite late. So that's what we did in terms of surgical scheduling. The next one is about a higher level, so more strategic level around modelling for policy. And so how Healthcare 4.0 can help our decision makers in central government, as well as our decision makers within hospitals and GP clinics. So this is some COVID modelling. I'm guessing a lot of you have probably seen some COVID modelling, so I'm going to go through this relatively quickly. It's a standard compartmental model. We added in the idea of ward stays in the ICU. This is some plots showing how well it worked. And so the dashed ones are the actual and the other ones are various simulations. And if I zoom in a little bit, you can kind of see the dashed one here around the number of people ICU, and then the blue one here, number of people in wards. So our simulation seemed to be reasonable in terms of the stress on the health system. And then also we did another piece of work, which is mostly done by my colleague Cameron Walker, looking at these models are assuming that your health system has the same number of people all the time, but actually, as we all know, health workers get sick. So he started looking at, so this is a plot of health workers on those compartments. And so the effect of you having a reduced capacity, so then health workers exposed to more patients, there's a higher likelihood of them getting sick, and then you have less health workers and less capacity, and it sort of snowballs. And I guess the main thing I want to say about this COVID-19 modelling was in New Zealand, there was a lot of cooperation between modellers and decision makers. And for me, that's one of the reasons why our response to the pandemic went so well. And I would really like to see that happen in times when it's not an emergency. It'd be nice if modellers and government could work together all the time to sort of help healthcare work efficiently and use what sometimes are very critical and scarce resources in the best way possible for our populations. So I don't think it should take a crisis for them to listen to modellers effectively. So the last one I'm going to talk about sort of arose also from COVID-19, which is the idea of, does New Zealand have enough critical care resources or capability? And, I'm pretty sure the answer to that is no. I think we're about third to last in the OECD in terms of our ratio of ICU beds, which is really more ICU nurses to people. The Ministry of Health here in New Zealand wanted to see, well, where should we move stuff around? And so they came to us, and so Ilse Zedens, Cameron Walker, and I essentially built a large bootstrap simulation of what critical care looks like in New Zealand. It's relatively simple. We just generate arrivals from similar days, generate our lengths of stay from similar patients, and from that you can then calculate the occupancy over time. And there's some few rules about what similar days and similar patients mean, but I'll skip over that just in interest of time. So what it looks like is this. This is actual And then this is simulation, multiple replications. And so this is deseasonalized into, so this is the observed, and this is the random component and the seasonal component and the trend component. So you can see the main thing you can see in the trend is actually the number of arrivals is increasing, and that's because the population is increasing. And so then they had a few different scenarios they want to look at. So this is if everything just continued on with the growth factor in the population at a particular ICU at Auckland City Hospital. So you can see there's the actual and there's the forecast, and it sort of looks like it's trending up in a way that seems reasonable. The one on the right is what happens if we also take into account there's some unmet demand that we would like to be able to service, but also COVID. So this one essentially is saying, what does our ICU occupancy look like given that COVID is going to be around? You can see there's quite a big jump there from this one. And so there was a few other different scenarios around moving different types of patients. So one of them was moving neurology patients from Dunedin to a reasonably nearby centre, Christchurch. What would that mean for the ICUs in both cases? And reasonably soon after we finished the study and presented the reports, and I'm sure we weren't the main reason, but I like to think we contributed, New Zealand invested a significant amount of money in improving our critical care resources. So I don't think we can officially take any credit for it, but I like to think that some of these plots at least got into the decision makers process. So in terms of modelling for healthcare policy, I mean, I think it's not really officially artificial intelligence or machine learning, because we're really machine learning, but I do think that it took the idea of digital twins to a strategic level and a national level. And we found that even these simple models are really useful for informing what was going on. And there was a lot of interest from Ministry of Health about how they looked. And they compared it to their own different types of analysis, and they were doing a much more aggregate analysis, but the results were similar. So it then meant that they really had a lot of trust with us with trying those different scenarios out. And as I said before, it'd be really nice to have these models ready to go. So it'd be nice not to have a crisis for these models to be put in place, particularly around pandemic response. But actually, I think the critical care was really also a response to the pandemic, or just as I said, the health system in New Zealand straining. And so one of the projects I'm now working with in the Global Partnership of AI is taking some standard data that's captured frequently around non-pharmaceutical interventions for pandemic response, also numbers of infection, which is available lots of different places like from Johns Hopkins, and then calibrating what the parameters of the model look like dynamically as those data sets update. And have those models ready to go. So rather than have to throw a team together quickly and get lots of people together and emergency access to data, why don't we have this stuff available and just running away in the background all the time? And that way, if anything happens, we can use it, or maybe we can just use it in our everyday decisions about. I know one of the ones that was looked at one point, also the critical care, for instance, is our critical care ready? There was something else about ophthalmology, where the treatment pathway for ophthalmology was changing, and they need to know, did they need more ophthalmologists or more appointments or those sorts of things? So answering some of those business as usual questions at a high level would be really useful for the people in charge of health in various different countries to have on hand. And I think that capability is there. So that's the end of my case studies. I'm just going to talk a little bit very briefly about what I think this all means, and then I'd be very happy to take questions. So part of the wrap up is we've worked with lots of people, and so I think there is interest broadly, and they're not all small, easy places either. So these are some of the largest hospitals in New Zealand. We have done a little bit of work in China, and they came over and compared these hospitals, and they were like, yeah, those are pretty big ones. So we think what you do with those hospitals will be transferable to some of the hospitals in China. The engagement, don't worry if you can't read this, you're not really supposed to be able to, but essentially each of the columns are different areas I've worked with. The different colors are the kind of projects I did. So are they PhDs or honours year projects or so on? How did we get those projects? And a lot of it was word of mouth, going from place to place. And I guess the main reason for the slide is that our interaction or our engagement with healthcare has been long and complex itself. It would be nice if it were less complex. It would be nice if we were just a think tank and health would come to us all the time and be able to do cool stuff. That's not really how it works. But also building relationships and having that word of mouth spread so we can do interesting things, various places. So if you're interested in helping healthcare, be ready for a long game. It's not a short thing, but I've really enjoyed it. And the main reason that my colleague Cameron and I got into it in the first place is we live in New Zealand, so we want it to be a healthy society. Hence, we are in it for the long game. And our kids and our loved ones live here too, of course. Here's what we do it in, all kinds of things. Mostly R and Python lately, lots of different optimizers, Java for JAMSIM, and we're as part of our work in healthcare, we're now trying to create a new standard for conceptual modeling and simulation, and then building that into our JAMSIM models. Here's a lot of the people I work with. So the main people in ORA are Cameron Walker and Tom Adams. So Tom is the Cam I do pretty much everything with. Tom's the postdoc who did the surgical scheduling. Ilse Zedens, who's probably the reason I'm even talking here. Nick and Melanie. So Nick's at TU Graz, Melanie's at Darmstadt, although I think she's moving soon. Te Puna Matatini, which is the Centre of Research Excellence. And also the operations, ORAS, so Operations Research Applied to Health Systems, has been a really great conference to meet people and just understand that what we're doing is, of interest in New Zealand, but also quite interesting globally as well. And plus all those healthcare people I work with, I mean, I can't emphasize enough having good relationships with people on the ground is so important for any of this stuff going forward. And so the main question I have really is now, I've shown you some of the things what I think Healthcare 4.0 could be, but I don't know much about what any of you do, but it'd be really interesting to see, can we put all our modeling and our AI, our machine learning and data science and make healthcare systems work as well as possible. So ngā mihi, it is, thank you very much for listening, and I'm more than happy to take any questions.